I'm very happy to see you on screen. This is the fourth and last FMER Advanced webinar that we organized for this year. So I'm very happy to have as a guest speaker our colleague from the Institute of Health Science Education, Professor Monica Molinaro. So as everybody knows, it's customary in our webinars that are our graduate students who facilitate the event. So as I said before, we have currently 3 master's students in the medical education concentration in the program of family medicine. And they are, the 3 of them, they are affiliated with the FMER, so they will run the show. Okay, so Raymond, Sima, and thank you very much for helping us on this. And the Zoom floor is yours. Go ahead.
Thank you, Dr. Rodriguez. Hello, everyone. My name is Raymond. I will help to moderate today's FMER Advanced Research webinar with Sima, and Odd will help moderate and also manage the chat. As Dr. Rodriguez mentioned, we are master's students in the Department of Family Medicine at McGill under the medical education concentration. So before beginning, I would like to acknowledge the land that McGill is located on. McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. Sima?
Today's research webinar, I would like to introduce Dr. Monica Molinaro, an assistant professor at the Institute of Health Science Education. Previously, Professor Molinaro was a Banting postdoctoral fellow in the Department of Family Medicine at the McMaster University, where she was also a merit scholar. She completed her PhD in health and rehabilitation sciences at the University of Western Ontario, where she conducted a critical narrative analysis on pediatric oncology nurses' stories of moral distress and worked as a research associate at the Center of Educational Research and Innovation. Building upon her expertise in using narrative methodologies to examine experiences of moral distress, Professor Molinaro uses a variety of qualitative, critical, and interpretative methodologies to provide understandings of how moral distress, as a result of institutional and provincial policy, has a bearing on health outcomes, future healthcare deliveries, and staff well-being.
Today, Professor Molinaro will be discussing we're still trying to dig ourselves out of this experience of moral distress in Canadian family medicine worker during the COVID-19 pandemic. This presentation will highlight the result of a qualitative case study exploring the experience of moral distress in individuals working with family medicine in Ontario and Alberta during the COVID-19 pandemic, drawing attention to how family medicine workers attempt to respond to rapid shift in provincial policy, healthcare system pressure, and needs for their patients.
Questions and comments from the audience are welcome and can be posted on the chat, or people can raise their hands after Professor Molinaro's presentation. This webinar will be recorded and will end at 1:30 p.m. And for those who do not wish to be recorded, please turn off your video now. And without further ado, Professor Monica Molinaro.
Great, thank you so much, everyone. What a great introduction. So as stated, I'm going to be presenting the findings of some research that we've been doing over the last couple of years around experiences of moral distress during the COVID-19 pandemic. And in this case, and for the purposes of today's presentation, it'll be about the experiences of family medicine workers, both in Ontario and in Alberta. So to get started, just very quickly to contextualize where I'm coming from in terms of this research. I am a qualitative health researcher with expertise in narrative methodologies and expertise in examining experiences of moral distress or morally or ethically complex healthcare. And so a lot of the work that I've done over the last few years has been about experiences of moral distress in healthcare workers in different fields and in different clinical contexts. And so for the purposes of today's project and today's discussion, I wanted to start off by talking about moral distress. And I want to note for everyone too, please, if you have any questions or comments or anything of the sort, please feel free to raise your hand. or ask your question or say your comment whenever you like. This presentation and this conversation is pretty easygoing. And my hope is I have time reserved for some quotes and some anecdotes that were shared by our participants in this study. And the hope is to have a discussion about whether or not we consider these stories to be instances of moral distress, if we find that there's characteristics about them that seem different in the way that we think about moral distress, or if you're a clinician yourself or do work with clinicians or do research in the realm of family medicine, does this resonate with experiences you've heard about or experiences that you've had yourself? So once again, feel free to interject at any time. I'm pretty easygoing about these things, but I will start with talking about moral distress really quickly. So moral distress was originally conceptualized by Andrew Jameton, who is a nursing scholar. And he did this to acknowledge the needs of nurses and try to establish nursing as a respected profession with its own set of duties and obligations. And the conceptualization of moral distress that he put forward, that's the most commonly known understanding of moral distress still, is when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. And since this original definition and conceptualization came out, there's been a ton of literature coming through, specifically in the health sciences and in relation to the experiences of healthcare workers, that have built upon or taken something from or tried to establish a better definition in some capacity of what moral distress is and what moral distress means. And so what makes moral distress a little bit difficult to tease through at times is that when you think about healthcare and healthcare professions, there's this underlying ethical tension in these professions, or there's this underlying ethical mode that's always in the background of engaging in health and healthcare delivery. And so when thinking about moral distress and what moral distress means, it's gotten more confusing over time as people have presented more conceptualizations and trying to differentiate it between that's just the ethical nature of healthcare and healthcare delivery. And so in the last few years, especially because of the advent of the COVID-19 pandemic, moral distress has essentially become theoretical mud at this point. A lot of the time, what's been happening is that moral distress has been conflated with other terms like burnout, stress, anxiety, depression. It hasn't been used in the right context. People are alluding that they're experiencing moral distress, but they're actually kind of talking about a different phenomenon. And while moral distress is related to all of the phenomena that I've just listed, it is a very distinct phenomenon from these things. So one can experience burnout and be experiencing moral distress, and those two things are related, but it is important to keep them separate from one another and understand what each of them means. And so we ended up during the pandemic applying for a CIHR operating grant in which we were successful, thankfully. And the project that we went forward and conducted was a qualitative case study across Ontario and Alberta to examine experiences of moral distress in healthcare workers. And so what we really wanted to get at was understanding how moral distress and moral injury, if you've ever heard of the term, manifested in healthcare workers throughout the pandemic, because the pandemic presented this really extreme and really unique circumstance to explore the phenomenon and to see if moral distress is based on constraints. Is this moral distress that happened in the pandemic based on historical constraints that have always been present and maybe become exacerbated as a result of the pandemic? Or did the pandemic present new circumstances for which people are now experiencing moral distress? And if that's the case, what does it look like and what can we do about it? And so in order to do this, we conducted a qualitative case study, which is presented by Miriam. And the point essentially was to really dig into these individual cases. So 2 ICUs or critical care units, one in Ontario, one in Alberta, and 2 family medicine practices, once again, one in Ontario and one in Alberta, and really dig at the context in which they were operating during the COVID-19 pandemic. So we wanted to make sure that the units that we included as cases were ones that dealt with different patient populations, had different structures in terms of remuneration, or different in terms of their size, as well as geographic location, whether they were in the community or if they were an academic center in some capacity. All of this variety was really important to us because we wanted to see if moral distress did manifest differently or was facilitated in different ways. And in order to kind of get at these experiences of moral distress, we conducted semi-structured interviews with each participant, one semi-structured interview. And we also did a bunch of document review. So in this case, what document review was analyzing any provincial policy documents that may have been released, any institutional policy documents or guidance or communications that may have come out at the time. And all of those documents were supplied to us by members of the case if they remembered or had access to any of that documentation to help build the context for each individual case. So recruitment is done. We are now writing up the findings of our study. And we were very lucky with the cases that we ended up selecting in that we had so many individuals that were willing to participate. And so once again, for the purposes of today's presentation, I'm only going to be focusing on the family medicine practices that we recruited from. So you'll see in total, we recruited 25 participants from our family medicine sites. And these individuals were working in a variety of roles. We were able to get registered nurses, registered practical nurses, admin assistants, or people that were working in administrative roles in these practices, several physicians, as well as a registered dietitian and some social workers that worked at these practices. So the variety of the roles really helped us in examining how roles had bearing on one's experiences of moral distress, but it also really let us get at how no matter what role you're in, there's capacity for experiencing moral distress. And that's really important because a lot of the literature, and rightly so, has focused on the experiences of several healthcare workers, but has predominantly focused on nursing, which makes a lot of sense when you think about the spatial temporal positions that they occupy in relation to their patients. But we really wanted to make sure and understand how moral distress could potentially affect anyone that was working in a unit or in a practice at the time. So when it came time to analyze the data, one thing that was really important to us, and actually I should go back to data collection first, we never explicitly provided our participants with a definition of moral distress or provided them with any form of understanding of what moral distress was. In the interviews, we would ask questions that were related to moral distress. So we would ask questions that were like, tell me about a time that you knew the right thing to do for a patient, but you were prevented in doing that thing. Or tell me about a time that you were unsure about what you felt was right for a patient. And some participants did explicitly express that they had experienced moral distress, either once or over several instances, depending on what had happened. Other participants would narrate these stories that to us seemed quite indicative of moral distress. And at times there was discussion of moral distress in the interviews brought forward by the interviewers, but we didn't present the participants with any particular definition because we didn't necessarily want to put experiences of moral distress in a box. We didn't want to contain what could be interpreted as moral distress in case there was something different coming through in the participants' interviews. And so when it came time to analyze, you'll see that we did have a guiding definition that I've written on the bottom by McCarthy and Montbaird. And we used this definition essentially to go through every single transcript and pull out any anecdote or vignette that seemed indicative of moral distress. We would take each of those anecdotes and sit down, and this was myself and 2 research assistants who did this, and we would sit down and go, is this moral distress, yes or no? If this is moral distress, why is it moral distress, or why is it not moral distress? Does this example that we believe to be moral distress align with the definition that we've presented? If it does, how does it align? If it doesn't, and we still consider it to be moral distress, how does it differ from the definition that we've provided ourselves? And from there, we also wanted to look at what was the right thing in this situation, because what's considered to be right is informed by a lot of factors. It's informed by one's professional values, it's informed by one's personal values, it's informed by the institution that they're working in, the social, the political, the economic context of the time. And from there, we also wanted to understand what the constraint was. And if it was something internal, potentially, one's sense of confidence, as an example, or if there was something external, if someone was making links to broader policies or broader decision making or relationships with colleagues or anything of the sort, we wanted to understand what was impeding them or what was constraining them from doing what they perceived to be right. And so that guiding definition of moral distress, what I'm actually going to do right now is very quickly copy and paste it into the chat, just so everybody has it, because I'm going to be sharing some examples from the work that we did. And that way, if everybody has a copy of the definition to guide them, then we can kind of have a discussion about these examples and see whether or not people are interpreting it in relation to the definition, or if you're interpreting it as moral distress, but it doesn't feel like it aligns with the definition in some way. So before I present these quotes, there's just a couple things that I'm hoping everyone here is willing to consider as I present these quotes. For those of you that are clinicians, for those of you that are researchers, for those of you that are just interested in the topic, I'd really like to know from all of you, and I'm really hoping that we can have a discussion about this, whether or not the quotes I provide do seem like moral distress to you, whether they seem like moral distress in relation to the definition I've provided, or they still feel like moral distress to you, but they don't necessarily align. If you are a clinician, I'd be really interested to know if you feel like these examples align with your clinical experience. And if they do, would you still consider them moral distress? Do you consider this just an everyday ethical tension that's experienced in your work, or do you consider it something else? And for those of you maybe that aren't clinicians, but work with folks that work in these clinical environments or work with other individuals in clinical environments, does it resonate with the experiences of your colleagues? Does it resonate with the experiences of your staff? I'm just really interested to garner people's perspectives here, because I think that moral distress in part is theoretical mud, because we do imbue so many different subjectivities onto the concept. So my hope is that we can kind of have a really fruitful conversation about some of the quotes that I'm about to present to everyone. The last thing that I do want to say about these quotes as well is, because these stories were interpreted in relation to moral distress, a lot of these anecdotes that I'm going to share with everyone might be difficult emotionally in some capacity. So please feel free to turn your camera off or take a break from one of these stories if you find them to be difficult to go through. I just think it's important to just let everyone know that sometimes these experiences are difficult, and I'd rather everybody know that up front before we dig into them a little bit. So with that, also, I want to say that some of these quotes are quite long. I will be reading them, so please don't feel like you need to strain your eyes. But my hope is, as I present each quote, I would be interested to know what everyone's interpretations of these quotes are. So with that, this is the first quote that came from a family physician in Ontario, who said, "I know someone that came in and we did a pap test and it was fine. And then afterwards, she started bleeding, but I didn't think maybe it was sort of back to normal or whatever. She made an appointment to come in. She didn't. We waited a few months and it ended up being cancer." And so, you know, something like that, we could have seen this person sooner. And now the delay investigations because of the backlog stuff. I'm sure you've talked to other people about that. Oh, well, this cancer was now caught at an advanced stage because we got the CT scan like we should have gotten a year ago, and we just got it. And so there's only so much we can say, and there's only so much we can do about the system, but the patients are the ones that are still suffering because we're still trying to dig ourselves out of this. So with something like this, does a scenario like this feel like moral distress to you? Would you interpret it as moral distress? Does it resemble something different? Does it resemble something similar to what you've experienced? I'm just curious to hear people's perspectives. Roland.
Okay, hi, can you hear me?
Yes.
So, my first thought just listening to the story is I'm a little confused. And it says it ends up being cancer, but what kind of cancer are we talking about here? Because presumably, if a pap test was done, someone looked at her cervix and they would have seen the cancer with their eyes if it was cervical cancer. So do you know what kind of cancer we're talking about here?
In this case, the person didn't want to note what kind of cancer it was in case it was identifying potentially.
Okay, because that, it could be an endometrial cancer, which wouldn't be seen on a pap test. So there could be some remorse or regret, but I'm not sure that I hear the doctor saying, oh, it's the system, not anything to do with me. So I don't think this has elements of moral distress in it, Monica. That's just my 2 cents.
Yeah, no, definitely. Thank you for sharing your perspective.
Yeah.
Kate, did you have your hand up?
I did, and then I realized that the insight that I had into this is not from a clinician perspective, so that's not what we're really talking about.
No, but I'm still interested to hear your perspective on it if you had a different perspective.
No, it's not a different perspective at all, and I like the concept of moral distress a lot. All I wanted to say was I did a big study of the impact of COVID policies on perinatal care in Canada, and this kind of example resonates a lot with experiences that birthing people have had with like complications that would have been caught ideally much more quickly if they had had good follow-up care, but instead they suffered for a long time and things became a lot more serious than they otherwise would have been. So just to say that it resonates a lot with what I've seen in another context.
Yeah, thank you. This example in particular was one, we had multiple examples like this where, as you said, Kate, the physicians or the nurses or the clinicians that took part in the study had these very negative feelings about the fact that their patients' diagnostics were delayed. And as a result, some of their patients ended up being diagnosed with later stage cancers or later stage illnesses or more severe illness than what would have been diagnosed if there weren't those backlogs in some capacity. And so for us, it was really interesting to tease through because we were trying to figure out, is this just guilt? Is this shame? Is this moral distress? Because a lot of the sentiments that were reported to us were about the fact that, I wish my patient had gotten this sooner. Like there was almost this assumption of personal responsibility in some capacity. While there is acknowledgement that this is a systems issue, there was still this personal piece that was taken on, or a lot of this was internalized by a lot of the individuals that we had interviewed, where they felt like they ultimately still shared some semblance of responsibility for the fact that their patients were being diagnosed much later, or that their patients were now finding out that they had late stage illness in some way. So it was interesting for us to tease through as well, because guilt and shame are considered moral emotions in some capacity. So then it became teasing through whether or not feelings of guilt could potentially also be feelings of moral distress or an experience of moral distress, but not necessarily being verbalized in that way. Chara.
Yes, but I mean, getting back to the definition of moral distress, my initial understanding was it's something prospective. So you have a patient, you have a case, you know what to do, but you cannot do it because of these institutional constraints.
Mm-hmm.
Whereas this example is most ex post, then you regret the delay, but it's more, I think it's more a passive stance that what I initially understood moral distress is, but it was just my understanding, just a comment.
No, definitely. And we got into discussions about this too, as well as what constraint actually means in some capacity. And here we were trying to tease through, can constraint in the context of a situation like this mean delayed screening? Can a constraint in this case mean that resources have been pulled from these screening programs, and as a result, these family physicians aren't getting the results in a timely manner? Like, would that count as a
Okay.
constraint in some capacity. So if it does, then we're teasing through, is this moral distress because the physician knows the right thing to do is to get these diagnostics taken care of or get these tests done and send them off for screening or get the results back. But if there's such a backlog in the system and these physicians or these clinicians don't have any control over that backlog in the system, could that be morally distressing?
Yeah, but the experience for the provider is exposed. So I mean, the temporality is different. Where
Yes.
to place this experience when you are able to do something and when you are just facing a situation that you didn't know before and you have not control over. I think there is a nuance there.
Yeah,
I
it
think,
is.
but anyways.
And we had discussions about this as too, and we understand that our participants are recounting experiences to us. So we understand that the stories and the anecdotes that they're sharing aren't things that happened live that day in any way. But is it possible that if you're experiencing a scenario like this over and over and over in your practice, even now there's still backlogs, at least in Ontario, there's still, and I'm not sure necessarily about the context of Quebec, but is it safe for me to assume that there's also backlogs here still in screening and diagnostics? If there is it possible that you're experiencing these things so frequently and so often that even though this one experience was a past experience, if this is something that's consistent, could you be experiencing a very low murmur of moral distress as time progresses if this continues to happen?
I got it. Thank you.
Yeah, thank you.
I also want to mention that Dr. Dove stated that for sure, the previous quotation, for sure, moral distress.
Oh. So one person definitely thought it was moral distress for sure. Distinguish between distress related to past programs of screening versus delays in trying to make a diagnosis in people with symptoms. Yes, I think that's a really important point too, Roland, as well, for sure. And we're kind of teasing through these elements as well and trying to figure out if this is moral distress. Are we relating it to paused programs of screening or delays in screening or delays in diagnoses? Or if the both of them are related and both of them are conducive to experiences of moral distress in some capacity.
Well, you would think, just to jump in there, Monica, like when someone has symptoms and you're unable to get them the specialist care they need, that is a much more distressing situation than when someone is just anxious because they haven't had a mammogram in a year and a half or 2 years, Yeah. So I think that's an important distinction to make. Like I experienced the former, as a clinician in 2020. A woman who came in with a breast mass, someone I knew very well, and I was struggling to get her mass evaluated properly because things were, as they were very difficult to get anything done at some point unless you were acutely ill, So that was a distressing situation, but yeah, just wanted to say we need to sort of make that distinction between screening and diagnosis.
No, definitely. Thank you for that. And I think that the experience that you've had in terms of knowing that something is wrong and you're trying to get that specialist care and get a diagnosis or get that done was a very similar experience to a lot of the physicians that we interviewed in this study. Some of them, though, in terms of that distinguishing, some of them didn't necessarily make that distinction between trying to get that specialist care versus just the delays that were happening. But it's a very important point, and I fully agree with everything that you've mentioned as well. Case management literature as well. I'm just reading, Paula, I'm just reading your comment. I don't know if there's something that you wanted to say about it, Paula, or if you were comfortable just...
No, not at all. I usually have lots to say, so I tend to type rather than take up time.
No, I appreciate it. Thank you. I'm going to move to the next example as well. This example came from an administrative assistant working in our family medicine case in Ontario. And so she said, last week I had a lady cry on the phone to me that she doesn't have any insulin left and the doctor won't renew it. The doctor's next phone call is in a week, or is a week and a half away. And she wasn't willing, and by she, we mean the doctor, wasn't willing to fit this patient in, and it kind of made me cry a little bit. I ended up putting her through to the clinic manager. No patient should ever feel like that from their family doctor. They deserve care and attention and medication renewals, especially when this doctor has been off for a while for maternity leave and just taking back over. It's morally wrong. It's heartbreaking. I do everything within my power to kind of help get around if she's being like that. I've told patients, call back for the after hours and get with the on-call physician. There was one patient I took a script to another doctor and was like, hey, their family doctor won't fill this. Can you fill this? I ended up getting a message from the doctor saying that I should have come to her first, but I had already come to her. So I sent that message back saying, we did have this conversation and you chose not to renew the medication and this patient needs it. And I'm sorry if this gets me in trouble, but it's worth it.
Okay, so that one's not ambiguous.
So you find this one to be like, yes, moral distress, 100%.
Yes, I do.
I'm seeing nods in the crowd as well. Did anyone else have any particular thoughts or feel like I agree with Roland? It seems like everyone's in agreement here. What's one, and a question that I'm going to pose to everyone in the office, because this one seems a lot more clear cut than the previous example. But what I find really interesting about this case was that this person was ultimately able to do the right thing in that they were able to get this patient the prescription that they needed. So the question that I want to pose to everyone here is, if you ultimately are able to do the right thing, can you still experience moral distress in the process? Because when you think about the conceptualization of moral distress, it's about constraint on doing what is right. And so this raised kind of this philosophical question for us in terms of, well, what happens if there's a delay or moral distress happens in the process of trying to figure out how to do the right thing? Is that something that can happen? Can you do what is right but still experience moral distress?
No question. I mean, it's just it's a timing thing, you know, like this person went through a period of difficulty. It was eventually resolved, but she was distressed during that period of time.
Mm-hmm. Yeah. Chara.
To me, there is no doubt that this is moral distress. She had a scope of action, but other staff, administrative staff in her position, wouldn't have undertaken that pathway, and it would have been okay. So you have your patients, you cannot ask other people to take care of patients that are who have other physicians. So she was very proactive. She was crying. She thought, okay, even if I get in trouble, I will do it. So she was particularly proactive, but she experienced moral distress because she had to go against her. And she, anyways, to me, it's not a, she extended her scope of practice, maybe for her personality or for whatever, her values, whatever, but she was doing even things that maybe in another clinic wouldn't have been accepted for the sake of the patient. So to me, it's moral distress, definitely, because she was experiencing trouble, physical trouble. She was crying, emotional as well. Okay, if I have a labor trouble, I will do it anyways. Maybe the definition of moral distress is multifaceted, and and there is many different things for many different people. But anyways, that's
definitely. And this was something that we spent a lot of time teasing through again, because the definition that I provided of moral distress is pretty much constraint on action that you believe is right. In this case, this person was ultimately able to do what they believed was right, and they were able to get the prescription filled for the patient. And so it raised questions for us in terms of thinking about what constraint on action meant, but also about maybe there's something there about the decision-making process or working through the options that are available to you, and also bringing in thoughts about power or agency or autonomy in one's role as well, because this individual was an administrative assistant. So they're not the person that can sit there and fill the script for the patient and get the script taken care of. They have to use whatever agency and power that they have in their role to make this work as well. So it became interesting for us because we thought this was a very clear-cut example of moral distress right away. But when we went back to the definition, all of a sudden we were like, this doesn't seem to align. There seems to be some factors that we need to start taking into account here.
Or maybe, as I said before, the definition of moral distress can be nuanced because context is different and make us part of the equation as well. And I definitely, the personality of people involved in another administrative staff with being less driven wouldn't have acted in that way.
Mm-hmm.
Okay, and would have felt constrained. Okay, this patient physician says there is nothing that I can do. Anyways, I will stop.
I appreciate it. No, thank you, Charo. But it did make for a very interesting example, and I like presenting this example to everyone because it seems that it really shifts the narrative on what moral distress might potentially be for different people. I will move on to the next example, though. This one came from an administrative assistant, or in this case, I believe this was a nurse administrator in Alberta at our Alberta Family Medicine site. So this person said, at one point, we essentially stopped all of our case management care. I was trying to come up with the word for it. So as nurses, we would carry a case of patient, and then we would go above and beyond to do things like, how are you getting your medications filled? How are you getting food weekly? Are you attending your other doctor's appointments? So that type of additional support that made a huge impact and a positive impact on the healthcare system. And it reduced ER visits significantly. And at one point, we were essentially forced to stop doing that because what we needed to do to support COVID. So we were helping to support the 811 call center, and there was definitely some distress around what's happening to our patients. Like their health conditions don't magically go away. They didn't magically become independent and be able to sort out their own issues and challenges. So now we've basically abandoned them and kind of thrown them out to the world to say, well, you've got to fend for yourself. We were making thousands of phone calls a day to people to say, hey, you're positive for COVID. So we were kind of torn. There's this abandoning of our patients, and now we have this huge responsibility. And if I don't go through my list, no one else is there to pick up the slack and do those calls for me. It was mandated from the Alberta Health Service. And that was when we stopped taking care of our own case management patients. And that's when physiotherapy stops, social work stops. We're no longer doing this. Dietitians were stopped. We weren't providing any of those services. All these healthcare workers now got put into supporting 811. Nurses got initially supported or pulled into that area. And then, of course, because we're nurses, we got pulled into swabbing and immunizations. So how do we feel about this example?
Well, I mean, the key word there is abandoning. That leads to distress. So it's pretty clear.
Yeah. This one felt pretty clear to us as well, but once again, it raised another series of questions in that it was evident that there was moral distress coming from these nurses in the fact that they felt like they abandoned their patients, but simultaneously the constraint on their action was doing COVID testing and informing individuals about their COVID test results, which were necessary for that period of time, especially in that initial wave of COVID when tests started coming in extremely frequently. So it brought up questions for us about what happens when you're tied between two things that you think are potentially right or considered right in some capacity, because this COVID response is definitely considered right in that it made sense for the period of time when there was a surge of COVID cases to be swabbing and doing the immunizations and making the phone calls and making sure all of that work was done, but it came at the expense of the patients that they were engaging in case management with. Simultaneously, if they prioritized the patients that they were doing case management with, they would be getting the care that they need, but all of this COVID work would fall in the background as well. So this was a situation that I think that we ultimately characterized as morally ambiguous in some capacity, in that it felt like you were stuck between two rights, and maybe you weren't able to do what you believed to be the most right at that time. Once again, Charo, kind of integrating your point of moral distress is actually a lot more nuanced than what we originally considered it to be. Because previously, when you think about constraint and conceptualizations of constraint, it's always one bad versus one good, or one wrong versus one right. And the constraint is usually the thing that is wrong, that prevents you from doing what's right. But what happens when you're constrained between two things that are ultimately right, and maybe one right takes precedent over another right? Ooh, let's see, I just saw a couple comments come through. The dilemma of making priorities. Oh, and Chara. So maybe Roland, did you want to say anything about your comment, and then Robert after?
I mean, you talked about doing what's right, but there's right and there's righter. And, you know, I think it's not a black and white issue here. It's very much the question of priorities. You know, you mentioned that people needed their shots and they needed to know if they're positive, but the nurse was pulled into that. You know, her job was to do something else. And so from her perspective, she's probably struggling morally with the issue of, you know, well, which one is righter? And what are the consequences of me abandoning my patients, you know? So that's the dilemma for her.
Definitely. Thank you. Robert, was there anything that you wanted to say in relation to your comment in the chat?
Hello. No, I was just thinking, I'm involved in postgraduate education. We often talk about health advocacy to residents, and I was looking at the preamble from the CFPC that talks about physicians as supporting or leading mobilization of financial, material, and human resources. But I'm not sure that healthcare workers always are able to kind of change those systems or work around those systems. So for me, it really comes down to that idea of agency, or kind of an ability to either influence the system, or, as was just pointed out, make a decision around a particular action, because I think we're presented with a lot of competing demands all of the time in healthcare.
Okay, thank you. At this point, we, as part of my postdoc, I had done a previous study about moral distress in family physicians that exclusively or very explicitly work with individuals that are experiencing or have social inequities of some capacity. So issues with housing, issues with income, issues with employment, transportation, and all of those factors. And when it came to looking at their experiences of moral distress, or where that moral distress emanated, there was really a lot of the moral distress essentially emanated from the fact that family physicians were the downstream solution to a lot of broader social policy decisions that had been made in some capacity. So as a physician, you can't necessarily prescribe someone safe housing, even though safe housing is ultimately the factor that would change the health outcomes of your patient. And so it's interesting that you bring up that point, because it seems like the system, in whatever we want to characterize it, was always this constraint on action. You can't prescribe safe housing. You can't magically increase somebody's income so that they can afford their medications or afford healthier food in some capacity. So while I'm going off on a little bit of a tangent, there's this broader system, or trying to address the issues of the system in these interactions with your patients becomes this instance of really constrained moral agency and not feeling like you're able to do something about it, which does seem conducive to moral distress. So with that, I don't see any other comments or hands up. Charo, I did see your hand up, but no?
No, yes, I want, but I put it, I lowered it. there is a scope, according to the result that you have obtained, as for educators. So there is something that at the educational level, postgraduate, as Robert has said, continuing professional development, there is something that from the perspective of family medicine education, there is something that we could do in order to, because obviously COVID-19 was an extreme situation, but as Robert has said, family docs are constantly confronting difficult situations, and they must make decisions in a context of uncertainty. So there is, what would be the repercussions at the educational level for helping these primary care professionals, family docs in particular, to better face these situations, to avoid moral distress, but in order to provide better care?
Yeah, I think that's a very hard and
Okay.
big problem, if you will.
It's coming.
Yeah. We're still trying to tease apart those issues. Is it about coping with moral distress? Is it about understanding? Is there something about education that is building these trainees up to think that family medicine operates one way, and then when they actually enter in practice, they're met with a completely different reality than what they were presented with in their education? Are they being guarded in some capacity in the work that they're doing, or protected in some way? A lot of these factors seem to coalesce, and we're teasing out some of those pieces still. I will move on to the next example though here. This came from another family physician here in, yes, dealing with unmet medical needs in patients and coping with moral distress, 100%. And I'll get back to that point after. This family physician in Ontario, once again, it brings up the cancer screening debate that we had talked about before. So Cancer Care Ontario had changed their guidance, and they had essentially shut down all cancer screenings for patients. So we couldn't even set up things like mammograms. We couldn't bring in patients for PAPs. We couldn't organize the colon cancer screening by mail. All of that was shut down. So patients really suffered because of that, because they weren't getting the cancer screenings that they needed. And I can just mention anecdotally through my palliative care practice as well, that we saw a lot of missed cancers because of that shutdown. A lot of unnecessarily metastatic cancers developing that would have been caught much earlier if the cancer screening hadn't been shut down. It made me feel really bad because everything has been put on hold to deal with the pandemic. So everything was focused on pandemic. Labs, the folks working at the labs were all redirected to processing COVID swabs. So there was staff available for other things. Everything was getting delayed, and we're even seeing the ramifications of that now, where even if you do a PAP, let's say, you don't see the results of that PAP for 6 months. Whereas pre-pandemic, we were getting the results of PAPs within days to weeks. So it's really thrown things for a loop, and things still haven't fully recovered from that aspect of things. We still haven't gotten many patients back on track for their cancer screenings, because now they have reopened cancer screenings, but patients either aren't aware or they've kind of just fallen off the rails and been lost to follow up. So we haven't had the opportunity to try and screen some of those people. Roland, do you want to talk about your last point in terms of wrong about the effect of delayed screening?
Right. So, a lot of doctors don't understand what screening does. And screening is about finding very early lesions, not stage 4 cancers that are metastatic. So if someone's, not seen today because of a pandemic, and in 3 months or 6 months or a year, they've got stage 4 cancer, that's not a failure of screening. Okay, that cancer was there, it was spreading, it was already, advanced 3, 6, 12 months ago. So they don't understand the point of screening, which is to pick up precancerous lesions like cervical intraepithelial neoplasia, or polyps that can be removed on colonoscopy. So they've over kind of dramatized the effect of delayed screening. And I think that is an opinion that will hopefully be brought out by research. To my knowledge, there hasn't been any research showing that we had a tsunami of cancer because we couldn't screen people in 2020. if you know of any research like that, please share it with me, but I haven't seen it. So I don't think there's any research to support this person's perspective either.
It's interesting. I honestly can say I don't know if I've seen any research about swarms of cancer being diagnosed or being treated now because of delays during the pandemic either, I will say.
Yeah, it's a common misconception that, you know, there were lots of people putting their hands in the air and saying, oh my God, we're going to have a tsunami of cancer because we can't do a mammogram for 6 months, you know, but the reality is they misunderstand what screening is and how it works.
No, it's a really important point and a really good point. With that then, even with this conflation, I would say, of these advanced cancers and the way that screening is being presented here, do you think that this person is experiencing moral distress in this capacity?
Yeah, I could answer, I think. I mean, what this person's upset about is they can't do what they're used to doing. Okay, this person's used to screening everything that walks through her door probably, and is not able to do that because of the pandemic. So is that distressing to her? Yeah, it sounds like it. Would that be what you call moral distress because she couldn't act? Yeah, but it was moral distress based on a false assumption or a false premise.
Thank you. No, thank you for your perspective. That's really helpful.
Yeah.
I see your hand is up, Charo.
Yes, my question is, following your conversation with Roland, my question is, do you have any practicing family physicians in your team that is helping you to interpret from a clinician perspective the stories that you have gathered among these clinicians?
Yes.
Okay,
So,
good.
yeah, we have a critical care ICU wing of the team, and then we have a family medicine wing of the team. So we have clinicians that are helping us interpret this and helping us understand what delayed screenings or what these delayed diagnoses actually look like and what they mean. And similar to Roland's point, if this person was being diagnosed with a very late stage cancer, how much of an impact did the delayed screening have in that?
Because one thing, your research is interpretive, obviously, critical interpretive, but it's obviously what people think, experience, live, and there is another reality that is more objective. I think Roland's argument, there is some research that has put in evidence that, as he said, a tsunami of cancers because over a certain amount of months, screening was shut down. So I think this contrast can be extremely interesting as well, for better understand what moral distress means and to better understand what are the measures that could be implemented from an educational point of view and managerial point of view, jet a policy point of view, to avoid unnecessarily moral distress, I think. Anyways, it's a fascinating research. Very interesting.
There's so many, and it's interesting too, because this research is so interpretive. My job, as a researcher and not as a clinician, when I sit and I read these anecdotes and I read these stories, I'm not even thinking or considering that thought about, you know, late stage cancers and what screening and what the implications of screening actually are. I'm thinking this person is very clearly experiencing some negative feelings about the fact that screenings have been delayed and what the implications of those screenings are. But then bringing in clinician perspectives helps us understand, you know, this is where the truth, and I use quotation fingers when I say the truth, but this is what the objectives or screenings actually are. And if someone is being diagnosed at this point in time with a late stage cancer, a screening 6 months earlier, like what would the implications of getting that screening 6 months earlier actually have been?
Anyways, it would be an excellent reflection.
Yeah, I see Francesca, you have your hand up.
Hi, Monica. So a quick question, are you using or are you going to do member checks?
Yes, so we had sent copies of the transcripts to each participant, essentially for them to review. And the goal of the member check was just to say, is there anything you want to add? Is there anything you want to clarify? Is there anything that you want to edit? And there was nothing significant that came from the member checks of those that actually responded to the receiving their transcript in some capacity. We aren't using, or we didn't use member checks with the goal of assessing the truth of the stories, of the participants' stories or the participants' anecdotes, but mainly just if there was anything else that they wanted to clarify, if they, after the fact, were like, oh, I forgot to mention this thing, that was the opportunity to do that. But we didn't really receive very much back from those participants at all.
Now, my reasoning was following up on Charles, that in your team, you do have experts in ICU, other family medicine, and I was thinking, what about the participant itself? Because he or she, if you're looking at experiences, is their experience.
Yes. Yes, 100%. And so we sent the transcripts back to participants, and some participants actually remained in touch after their interviews, because many of them found that this was the first opportunity that they had to really speak to their experiences during the pandemic with someone that wasn't a clinical colleague and someone outside of the context that was willing to listen to what was happening. So we were fortunate in that we had participants that were very willing to share their experiences and then also keep in touch with us after the fact to see or let us know how they were feeling about the study. So yes, the experiences, long story short, the experiences were very important to us as well.
Thank you.
Thank you. Let's see. So for the purposes of time, I see we only have 3 minutes left. So I think what I'm going to do is simply come to my end slide about what we're learning. And overall, and so I don't necessarily want to present conclusions because I think that we're still thinking really hard about what these examples mean and what those examples are showing to us about experiences of moral distress. But what's become very clear to us is that the pandemic was obviously a very extreme and unique circumstance that facilitated these new experiences of moral distress and really prompted us to think about what moral distress means and what moral distress could mean in terms of the pandemic versus elsewhere. And so some of the elements that we talked about today in terms of its alignment with the conceptualization that we used were in regard to being stuck between two rights, time and temporality. Could moral distress have to be one particularly distressing instance, or can it be a low hum that kind of is in the background the entire time of your experience and then reaches a crescendo at some point or another? We're also looking at the relationships between autonomy and agency and power, as well as the human experience or what it means to bear witness to something that's potentially morally distressing. And lastly, how can family medicine recover from this? It's I think it's quite obvious to everyone that family medicine throughout the provinces has suffered quite greatly over the last few years in terms of the rates of attrition and burnout. Also lots of retirements that have been happening over the last little while. And so some of the elements that we're trying to tease apart in terms of education are, do we need to present instances of moral distress to trainees to understand that this might be something that they can face in their practice, for them to contemplate, for them to understand, for them to have warning in some way? Are there other routes we can go through where we spend time really digging through economic policy, social policy, and understanding where their scope begins and potentially ends as a family physician in terms of what they can address? We're still trying to tease through these elements as well, because it's really hard to be able to prepare trainees for the full scope of what they may be seeing in practice, especially when you end up in a very extreme and unique circumstance as the COVID-19 pandemic. So we're trying to play with a lot of these elements still and figure out exactly what can be done, but maybe it just starts with presenting examples like this to trainees for understanding that these are things that have happened and can happen, and just gauging understanding of what their response would be or what they'd hope to respond with in some capacity and going from there. So I see it's exactly 1:30, so I will just finish off by saying thank you so much for having me today. I really appreciated it. I've included my email in the bottom in case anyone wanted to get in contact with me or had any additional questions outside of today. But once again, thank you so much for having me. I really enjoyed presenting my research and having these discussions with everyone.
Thank you,
Thank you.
Monica, for accepting our invitation to share the results of your investigation with us. Very much appreciate an excellent presentation as usual, because you are an excellent speaker. Thank you, everybody, for your